thank you for the faculty for inviting me to give this talk. I appreciate it. My talk's going to be about the opioid crisis and how spine surgery is involved in it and what kind of improvements we can make in it. As we know, the opiate crisis is a major issue. We've had dramatic improvements since 2010 till now with it. I have no relevant disclosures to this talk. So the opiate crisis is still a major issue. There's been a lot of funding in it. We have had dramatic improvements with it since 2010. Again, it was at its worst in 2010, and there's more notice to it and improvement that's being made in it, but still it's a major problem. The amount of overdose deaths in the U.S. is over 70,000 a year. In terms of majority of those is related to opioids. So out of all drug overdoses, over 60% of them are related to opioids. In terms of how many, there's about 130 patients that die a day related to opioid-related overdoses. And we spend about $12 billion a year in terms of opioid treatment and management. So there's a lot of money that's going into it. However, it's still a major problem, and there's a lot of room for improvement. So how are we tied into the opioid crisis? Would you say spinal ailments are part of the opioid crisis? The neck and back pain are the most common reasons for pain in the United States and around the world. Headaches is also part of that. So neck and back pain are some of the most common reasons for medical conditions associated with the opioid addiction. In terms of with opioids, if it's pretty clear through the literature, if a patient's opioid addicted and you do spinal surgery on them, they're unlikely to become opioid free. So if you do a spinal surgery on somebody that is on opioids prior to surgery, it's unlikely that they'll come off of opioids afterwards. And that's been well documented. There's several publications looked on that. So what do you do? The opioid crisis is a major issue. There's many overdoses. We're spending a lot of money on it. And if we do spinal surgery on somebody that's opioid addicted, they're not coming off of opioids after surgery. So one major area is to optimize the limbic system and pain pathways prior to surgery and after surgery. And I'll get into that a little bit afterwards. But a main part to understand is that fixing the radiographic problem alone does not alleviate the pain significantly. That is well documented. So as surgeons, we're there to fix the structural problem, but as the literature has shown, fixing the structural problem does not make the pain go away. A lot of times you could see that analogous to somebody having an amputation and that they still have the phantom limb pain. So alleviating the structural problem does not equate with having improvement in pain. And a big part of our outcomes is pain and disability that we validate in terms of clinical outcomes. So a big part is the interaction of the limbic system with the pain pathways. So this is a diagram kind of showing that how the pain pathways associate with the limbic system. In terms of the limbic system, again, we see that more as the primitive part of the brain, it's the emotional part of the brain. It's our reaction to stress and pain. And there's a great study by Dr. Baker out of UCSF. She's a foremost figure on PTSD, and she's shown that people with PTSD, she put subarachnoid drains in these patients and then put caspicin in their quadriceps. So it's an irritant. It's the same thing that's in chili peppers. And she put a subarachnoid drain. She looked at time 0, 2 hours, 4 hours, 6 hours, and 24 hours after injecting caspicin in their quadriceps. And the patients with PTSD versus the ones without PTSD had alarmingly high numbers of inflammatory factors in their CSF. Right after injection, and every time point afterwards compared to people that don't have PTSD. So there's a different relationship to pain with people with PTSD or different emotional diagnosis or mental illnesses to pain. So the same amount of pain produces a completely different response in terms of the limbic system and in terms of their CNS. Another thing that was interesting with that paper is that the blood-brain barrier actually is not fully true. There's actually 4 ways where the blood-brain barrier is actually open. And that's a different talk, but basically inflammation can cross through the blood-brain barrier. So this is a great point to kind of go over again, the difference in terms of structural problems as a surgeon versus outcomes. This is a study looking at predictors of long-term opioid use following lumbar fusion surgery. So looking at number 1, number 2, and number 3 in terms of predictors of becoming opioid-free, you can see surgery plays the least role. It's very negligible in terms of it. Number 1 was duration of opioid use prior to surgery. If the patient's on opioids for greater than 250 days, getting close to a year of opioids of use prior to surgery, extremely unlikely you'll ever get the patient off of opioids after surgery. You can look at the odds ratio is through the roof in terms of people that are on opioids for greater than 250 days. Untreated mental health issues was number 2 in the entire analysis. Surgical factors, like what the pathology is and how you did the surgery, anterior versus posterior, minimally invasive versus open, played a much lesser role in it. If it was a revision case, etc., played less of a role. This was looking at over 8,000 patients. This was in Spine 2017. So these factors play more of a role than the surgery itself. So it seems, again, as surgeons, our main focus is the technical part, how to do surgery, how to do it better, which is important. But we're beginning to realize the psychosocial parts play actually more of a role than the surgery in terms of technique and how to deliver the surgery. This is an amazing paper. This is a landmark paper, Spine 1992. This is 86 patients that had a microdiscectomy. So patients that had no childhood trauma, 95% of them had excellent improvement, which is analogous to what we expect. Microdiscectomy is, again, one of the slam dunk surgeries that we do. It's been well validated in the sport trials at 2 years and 4 years. And patients with no trauma, 95% improvement after the microdiscectomy. Patients that had 1 to 2 type of childhood trauma, these were categories of childhood trauma, one's emotional, one's physical, one's sexual. 72% if they had 1 to 2. If they had greater than 3 types of childhood trauma and had a microdiscectomy, 15% improved. So unlikely they're going to improve after a microdiscectomy. So for a slam dunk surgery, that's very easy to perform, very predictable outcomes, low complication rate. The patients that have more traumas are not going to improve versus patients that have no trauma will have a 95% success rate. Similar to if you do a meniscectomy, again, these are what we consider slam dunk cases, low cost of surgery with excellent improvement in qualities validated through multiple different studies. So the best thing is, Sig alluded to yesterday, is you got to look back in history. So, if you're going to try to improve a problem, look back and see how you can make improvements. So look at the literature. Heidi Prather at WashU, she's part of the PM&R department, prior president of NAS 2014, has had excellent literature on this talk. So this is kind of looking at how to optimize the limbic system prior to surgery or after surgery. So number 1, transition patients off of opioids prior to surgery. So what does that entail? Getting patients on membrane stabilizing medications like gabapentin, Lyrica, duloxetine, or muscle relaxers, which are non-addictive and do not enhance the limbic system, are great ways to do. So if you get them on a multimodal plan in terms of medications to get them off of opioids prior to surgery. As you saw beforehand, if patients are on opioids prior to surgery, it's unlikely they will come off of opioids after surgery. A lot of people see this as what we call an opioid cleanse. So coming off of being cleansed of opioids prior to surgery, which gives them a chance to be opioid free after surgery. If they don't go through this cleanse where they're off of opioids completely prior to surgery, it's unlikely they'll come off of opioids after surgery. Next is psychotherapy through the behavioral department for the chronic pain syndrome and the mental health issues. So addressing the chronic pain syndrome and the mental health issues is very important. It has been shown in the literature to improve patients to become opioid free after having spinal surgery. Next is physical therapy, specifically the ACT program. ACT program is a program that tries to, from a physical therapy point of view, get patients to participate and realize that pain, there's an acceptable amount of pain that you should have, and working through that pain. So a lot of patients think, if I have any pain, stop. Oh no, you can't move any farther. Physical therapists through the ACT program, helping them to realize there is a certain amount of acceptable pain and working through that so they can develop more of a range of motion and become more active. It is very important in terms of optimizing the limbic system prior to surgery. Smoking cessation and for alcoholics in terms of getting off alcohol, both of those clearly, alcohol and smoking is clearly shown that it enhances the limbic system, and they have functional MRIs looking at the limbic system prior to surgery, and on smokers and patients that are alcoholics. So trying to get them off of those. So these 5 things have been clearly shown in the literature to optimize patients prior to surgery. So the hypothesis of the study going into this is, if we do this in a prehab manner, so every one of these 5 points we talked about to optimize patients, if you do all 5 of those protocols prior to surgery, the hypothesis is that you will decrease opioid consumption and pain in patients going for spinal surgery. So these are patients that are opioid addicted and going for elective spine surgery. If you initiate a prehab program, which is again those 5 things, initiate all 5 protocols, that they would have decreased pain and decreased opioid consumption. So the study's design was a collaboration between the spine surgery department, psychiatry, psychology, pain management, pharmacy, primary care, physical therapy, and nutritionists. This was done at the VA system, and it was patients going for elective spine surgery that had chronic pain syndrome and opioid addiction. So elective surgery that had chronic pain syndrome and opioid addiction. And we compared the outcomes after surgery with people that had prehab and patients that did not have prehab. So had the standard, they had an elective problem and they had surgery, versus patients who were identified that were going to get elective surgery and then enlisted in this protocol and then had prehab prior to surgery. It was 89 patients versus 85 patients. And in terms of propensity matching, they were very analogous, the 2 cohorts. So these are the demographics and surgical parameters between the patients. As you can see, age was not different between the cohorts. They were very well matched. Gender distribution was not different. Again, this was the VA system, so there was more males than females. And in terms of what surgery was performed on these patients, the ones that had prehab versus did not have prehab, it was not very different. If they had ACDF, if they had posterior cervical fusion, if they had a combined anterior and posterior cervical fusion, A-lift, posterior fusion, combined anterior and posterior lumbar fusion, a microdiscectomy surgery, a laminectomy, revision, and the amount of levels treated during surgery was not different between the cohorts that had prehab and the ones that did not have prehab. So a very obvious point is that patients that had prehab were very likely to be opioid free at 6 months. So 72% of the patients in the prehab group were opioid free. The patients that had no prehab, only 8%. So then patients becoming opioid free after surgery that don't have a prehab program is unlikely. It matches what the literature shows, that they don't become they don't become opioid free. Interesting point is the patients that had prehab, they're not on opioids, but in terms of their improvement, in terms of the radiculopathy and actual neck pain or back pain, was significantly better than the prehab. They had a 6-point improvement in terms of their actual pain, neck pain and back pain, and a 6-point improvement in terms of their radiculopathy. Versus the patients that did not have the prehab, they had a 2.5 improvement. So they had some improvement, but the patients that were in the prehab had 6 points improvement, a dramatic improvement in their preoperative pain, and they were not on opioids. So it was very clear. Also, they had a better quality of life, the patients in their prehab, and they had a healthier relationship with pain. And I'll go over that again. Again, healthy relationship with pain means that their limbic system has been optimized, so they have a healthier relationship between how the pain pathway interacts with the limbic system. So if you look at their qualities 1 year afterwards, prehab group is 0.6, the no prehab was 0.6 improvement, and the prehab group had a quality of 0.8. In terms of the other ones, there's the CPAQ, again, it's a chronic pain questionnaire, and then a PCS, which is pain catastrophizing score. So this chronic pain questionnaire is looking at, despite them having pain, are they able to be active in life? Are they able to wake up and go to work? Are they able to do their activities of daily living despite having pain? It's a very well validated questionnaire. And it breaks up into activity and willingness to actually participate. And you can see in both those categories, the patients that had the prehab had better ability to be active and willing. So their ability to manage their pain and be active and willing is higher. Also, pain catastrophizing. Pain catastrophizing score is how do they catastrophize pain? So when they get pain, some patients, when they get pain, they're like, it's a part of my life, a little ache. Okay, some people, when they get pain, they catastrophize it. They're like, my life's coming to end, I won't be able to breathe, and I won't be able to go on. And so the PCS test looks at that, the pain catastrophizing score, and you can see the patients that went with the prehab cohort that had surgery had a significant improvement in the way that they perceive pain, in terms of they don't catastrophize pain. So they have a healthy relationship with pain, and they have better qualities. A very interesting point is something that I guess a lot of us also realize too. So you do know prehab, they don't have a lot of improvement in terms of their qualities, in terms of their pain, their radiculopathy, kind of analogous we saw with the microdiscectomy. But 86% of those patients that had no prehab were satisfied they had the surgery, and they would do the surgery again, which is a common thing that you see in these patients, that they still would do surgery and they would still do it again, even though their outcome measures weren't that impressive in terms of treating the structural problem. So you alleviate the structural problem to their spine, and they're not opioid free. They still have a significant amount of pain, and their metrics aren't that impressive, but they still would have the surgery. Again, those patients, the ones that have fibromyalgia, it seems that they're always going to the doctor's office, always getting procedures and continually getting procedures, and they're happy about it, and they feel like they're improving despite their metrics don't really show that. And the reason why that's going to be important is because cost effectiveness is going to be a big part of healthcare. It currently is, and it's going to continually become a problem, specifically in spinal surgery, because the cost of spinal surgery keeps on going up. And currently in the United States, our deficit to our GDP ratio is we have twice the debt to our GDP or production. So there is going to be cutbacks, because if you sustain that, then the U.S. economy will have catastrophic consequences. And really the only two areas that you could take money from are the military or healthcare. So you'll definitely see big changes in spinal surgery in the coming futures in regard to this. The patients that had prehab, 98% would had surgery again, and they were satisfied for results. So great satisfaction, but even the people that don't have it, very satisfied. What are key conclusions? Again, as Sig alluded to yesterday, collaboration is key with difficult problems. Getting different points of view, not being alone in surgery, as he alluded to yesterday, does help improve a dramatic problem if it be a difficult scoliosis case or a difficult problem like the opioid crisis. Again, it's very clear that over the last 2 decades in spinal surgery, a lot of the research and literature has looked at radiographic parameters in terms of spinal surgery. So we've been very focused on the surgical part, the treatment part in terms of research. So for a very good point is degenerative spondylolisthesis. Every single year at NASS, there's at least 7 or 8 presentations that goes over, do you do a T-lift? Do you do a posterior lateral fusion? Do you do a minimally invasive T-lift? Or you do a decompression alone? And those talks for the last 20 years, we'll keep on saying there's at least 6 of them every year. And so we focus a lot on that. We need more research and guidelines addressing the limbic system before and after surgery. It's clearly important in terms of optimizing the limbic system. Patients that are going to go, that are opioid addicted, going for elective spine surgery, some kind of rehab is important. This study did a prehab, which is difficult to do at institutions. Began in the VA system is very easy because it's a closed network system. And those type of systems is the best opportunity to do research because patients, all their services are in the same building. They can't go, essentially, it's very difficult for them to get their services outside the system. So it's well documented in terms of their treatment, their improvement, and you can capture all the data, and long-term follow-up is amazing. Every one of these patients have follow-up. So again, I think a closed network system is a great area if you're going to look in terms of research, looking into the limbic system in spinal surgery. A good part is with the opioid crisis, bring a lot of attention. There's a lot of funding for opioid. Again, NIH has a lot, every year it puts out large dollar amount of research funding for opioid improvement in opioids. So spinal surgery is very much tied into the opioid crisis. So we have a great opportunity to improve it in the United States. Again, a very important point, again, there's high patient satisfaction with surgery alone, despite the fact that their VAS scores are not dramatically improving and they're still addicted to opioids. So it's an interesting point, but as there's going to be a crunch for, in terms of healthcare and dollar amount, you're going to start seeing that these patients want to continue a procedure, but there's going to be probably more stoplights to prevent them from having surgery because we're going to be very focused on metrics. And the reason why is, as you can see this next slide, spinal surgery is extremely expensive. It's around $100 billion a year with a 6.5 increase per year. We're number 3 on the list of problems in healthcare. So in terms of healthcare, the cost of it is always between 18 and 24%. Again, when the debt ratio is twice that of our GDP, there's going to be a crackdown, and it's going to be one of these 3, particularly spinal surgery. So cost effectiveness, again, SIG has done a significant amount of research in looking at cost effectiveness for quality in spinal surgery, particularly in adult deformity. So this is going to be paramount because the cost is high. And this is a slide of Dr. Freeman and Watts looking at an x-ray prior to doing psychosurgery in terms of patients with mental illnesses, obsession, and severing some pathways through the prefrontal cortex in terms of improvement. I think this is a great slide because in terms of spinal surgery, we dramatically improved diagnosis and diagnostic tools. For this type of thing, we would have functional MRI and things like that. In terms of spinal surgery, we have MRI, multiple different type of imaging modalities and serum markers and et cetera to make diagnosis. And we have way better tools in terms of treatment of spinal ailments to minimize morbidity and mortality and optimize qualities. So our technology has dramatically improved both diagnostically and therapeutically. So I think that we can make a huge dent in the opioid crisis because we're highly involved with it, because back pain and neck pain is one of the more common reasons people are getting opioids. Thank you.